Habari za asubuhi. Naitwa Dr Hery Mwandolela, ni specialist wa magonjwa ya moyo, cardiologist. From a hospital called Hemeda, located in Bunju, on your way to Bagamoyo, Dar es Salaam city. I'm going to talk to you in the next few minutes, maybe 30 to 40, about very important area of cardiology, which is cardiac catheterization. I'm going to talk on the overview, the function of Cathlab, what are things which are done in Cathlab, what we have done so far in the past 2-3 years at our hospital, and I'll allow you to ask questions or to ask whatever you think you need to know so that we understand about this important service that is available in our country. This is briefly about me. Of note, in my CV, I always add like I've worked with Kairuki Hospital before. That's most important of all. Kwa na nyie mkiwa hapa hampotezi muda, you are working with a very reputable institution which has been part of growth of many important people. Kwa na mimi CV yangu naongezea hapa. Actually, niliofungua ile echo room back then when it was not functioning with Dr. Kaganda, nikiwa nafanya Master of Cardiology. Okay, so about our hospital is 15 years old now. We started from city center. Now we are relocated to Bunju. We are doing much specialty, but cardiology is our main specialty. And as of now, we have introduced in the past 2 years the high-tech service, which is cardiac catheterization. So I'm going to talk to you about the growing burden of disease, which is cardiovascular disease. As you may all be aware that cardiovascular disease are the leading cause of death worldwide. Actually, it's #1 killer, putting all the disease together. Tracking from 2017 to date, the number of deaths have been increasing. Until last year, 2025, the prevalence of all the percentage, cause of death was around 33%. We have around 60 million deaths every year. Out of them, 20 million of them are caused by cardiovascular disease alone, which mainly include heart disease and vessel disease. It is estimated that coming 2050, 35 million people will be dying of cardiovascular disease alone. So from 2017 going forward, the number of diseases is increasing, and as you can see, there have been efforts to decrease number of deaths from other causes of disease, but cardiovascular disease, which includes ischemic disease and stroke, have been increasing every time, from early 20th century going forward. If you look at this graph here, you can see the red dots means increase of the disease, and the black one is, the baseline number of disease. The two diseases, ischemic disease and stroke, and of course, chronic obstructive heart disease, obstructive pulmonary disease, have been increasing. For example, from the year 2000 to year 2019, the number of deaths have been increasing, while other diseases like neonatal conditions, tracheal disease, mental disease, diarrhea disease, and other infectious diseases have been decreasing. Efforts have been made, and the number of diseases have been decreasing, except for cardiovascular, which has been increasing over time. So we have a very big burden of disease causing many deaths. Despite efforts of trying to put them down. These have been already talked about. Initially, early 20th century, cardiovascular diseases were contributing only 10% of death. Come 2025, it's contributing to 33%, which is from around maybe 10,000 deaths, 10 million deaths to 20 million deaths per annum as per last year. Okay, and unfortunately, the disease and death affect the low and middle income countries, which are sub-Saharan countries, of which Tanzania we are among them. Lakini, we know that about 80% of death can be prevented by only adapting or practicing good lifestyle ambayo ina include chakula na mazoezi pamoja na kuzuia vitu ambavyo vinaongeza risk of cardiovascular disease. So we have this percentage of disease which we can take down by only practicing good lifestyle, ambayo sasa ndio inatuhusu sisi kwa sababu we are poor in this region, Sub-Saharan Africa. We cannot afford treatment and we cannot afford good and modern diagnostic facilities. So we have to mainly stick on prevention rather than to wait until we fall sick and then lose lives. Okay, the number of deaths is increasing, but the diagnostic and facilities to treat them is not going hand in hand. As of now, in our country, we have less than 10 Cathlabs in the whole country of 60 million people, while the requirement is actually more than 60 Cathlabs. When you world data, every 1 million people, you need to have one Cathlab. 60 million people, we have only actually 6, less than 10 Cathlabs in the whole country. While the number of disease is increasing, but the efforts to increase technology to handle the disease is not keeping in pace with the death and number of disease. Well, we have a lot to do so that we can take down the number of deaths, at least by early diagnosing and treating appropriately and timely. And here we're going to talk about the Cathlab. Cathlab is basically this arrangement with an X-ray source and a detector. You have X-ray source which is sending X-rays to a patient, and you have a detector which will pick the signals and transmit to a monitor which a doctor who is operating will see what is happening in terms of diagnosis and treatment. Here in the console room, I'm going to acquire monitors, somebody who will acquire the images and see all the hemodynamics which are happening while the procedure is going on. How does the Cathlab help to diagnose various cardiac conditions, including arrhythmias and ischemic disease? It also helps us to examine valves and sometimes cardiac function in terms of ejection fraction. We also use to measure intracardiac pressures or intravascular pressure, direct measurement of pressures. Hizi pressure tunazipima kwenye mkono ni non-invasive blood pressure measurement, but you can measure directly the pressures intravascularly using Cathlab equipment. You can also measure oxygen saturation and various levels of oxygen in the circulation by using Cathlab techniques. We can do other things like diagnosing blocked coronary vessels by a procedure called coronary arterial angiogram. You can do PCI, percutaneous coronary intervention, which will include balloon intervention and sometimes placing stents, which is called PTCA. So this is diagnostic and this is therapeutic or treatment by using Cathlab equipment. But also, we can do stenting of various types. There are different types of, pacemaking. Pacemakers of different types or devices for that matter. We have bradycardia pacing, but we have ICDs, CRT, which are procedures which will help either to, increase heart rate for those with bradycardia, that is complete heart block, but also for those who have lethal arrhythmias, we place ICDs which will abort lethal arrhythmias when they happen, and CRT for patients who have heart failure with a reduced ejection fraction who do not respond to optimal medical therapy. This is what is happening in therapeutic part of PTCA. You have a blocked vessel by atherosclerotic plague, which is after diagnosis, you do interventions to unblock the vessel. You go with a catheter, which is guided by a wire, and you do ballooning and then place a stent to open the vessel. Stent is basically like a frame of meshwork which will be ballooned and or deployed to open the vessel which is blocked. This is the example of a blocked vessel, and this is a balloon, and this is a stent. So that's what we do to open the blocked vessel. We can do also valve repair by using Cathlab equipment. We can take biopsies for some conditions which need biopsy, but you can also use Cathlab equipment to block congenital anomalies like PDA, VSD, ASD. We can also open the blocked valves, for example, mitral stenosis due to rheumatic disease, by using a procedure called the balloon valvoplasty. So all these are things which can be done in Cathlab. There are patients who have conditions like hypertrophic cardiomyopathy who need so-called alcohol septal ablation. This is the procedure which is done in Cathlab as well. So we can do a lot in Cathlab, including diagnostic and various treatment of different conditions, ranging from congenital to acquired conditions. CAG, or coronary artery disease, diagnostic coronary angiography is the most basic test which we do. And usually we use catheters to go into the vessels and engage into the vessels and inject a dye, special dye, which is called contrast, which is visible in X-ray fluoroscopy. And you see if there is no flow of blood into the vessel, then you diagnose blocked vessel. We put in percentages ranging from whatever the percent which you get, but we usually intervene when it is more than 75%. It is CAG is a standard gold standard of diagnosis of coronary disease. We have CT angio, we have CT calcium score, but CAG is the standard diagnostic test, gold standard. Kwa hiyo ukiwa una mgonjwa anafanya screening ya coronary disease, you can do CT score, you can do CT angiogram, coronary angiogram, but the conventional CAG, which is done in the Cathlab, is the gold standard of all the treatments. So these are the three major vessels which we are talking about in the coronaries. We have the left system and the right system. The left system, you have the left main artery, which bifurcates into left circumflex and the left anterior descending, which also have branches. And we have the right system, which is a single vessel, which also branches into smaller branches going down to supply the right side of the heart and the posterior part of the heart. So this is basically the anatomy of the coronary arteries. And that is, pictorial form, and that is from a diagnostic angiogram, how it appears. This is how it appears in when you take a picture, like you draw a picture, this is how you see them when you do coronary angiogram. And this is the example of left system, normal left system, which has the left main with the left anterior descending, and this is the left circumflex artery with the branches going down to supply the distal part of the heart. This is the right system, which is called right coronary artery, or RCA. And when you have blockage, this is how it will look like. You have left main artery, which branches into another branch, and here you have this continuation of flow. That's how you see the blockage. And this is another view where you have a normal vessel. The dark filled area is good flow because you see through, flow of the contrast through fluoroscope, and this is a blocked part. That is how you diagnose coronary stenosis. Okay, this is an example of one procedure which we were doing at our Cathlab. That is me with my colleague. So it is important to know ECG kwa sababu ndio the only way you can diagnose ischemic disease, being them chronic ischemic disease or acute ischemic disease. Two main things. One, non-invasively, you have to do ECG, and then you do coronary biomarkers, or cardiac biomarkers, which are many, but the most famous and the most useful one are troponin and CKMB. The whole secret lies into the understanding of T wave, ambayo hii ni mfano wa a normal ECG with a normal flat T wave. We have the P wave, we have the Q wave, R, S, and Q. P, Q, R, S. And this is a so-called J point. J point number unaanza kumeasure elevation from the baseline. So this is an example of elevated ST segment from the J point. Always remember the J point. Because sababu wengine sana confused, you don't know where to start. The so-called J point is your reference point here, ST segment elevation. Now you can have, we measure them in millimeters or millivoltage from 1.5 millimeters of elevation and more is regarded acute ST segment elevation, depending on shape and other things. Like in the whole understanding of ECG pertaining to acute ischemic disease, the understanding of ST segment with reference to the J points. You kama umeelewa jamani? Mimi nilikuja kuelewa nikiwa nafanya masters ya cardiology, nilikuwa sijuagi zamani. Kwa hiyo hii ndio simply ninavyojua namna ya ku. Kwa hiyo unaweza kuwa na ST segment elevation au kuwa na ST segment depression. They can both talk of ischemic disease. Even ST segment depression, you measured from the J point going down the baseline. Na utapima kwa millimeters kuona kama kuna depression au kuna elevation of ST segment from the J point. Sawa. Huwa natoa courses za short courses za ECG for those who are interested. Nyingine nimetangaza iko mwezi wa pili, sasa hapa natangaza biashara. Wale nao elimu for that matter, watakotaka wajoin, wanafundisha ECG in the simplest way. Kila mtu ambaye anakuja pale anaelewa na anashangaa mbona sikuelewa ECG miaka yote. Kwa hiyo I have a course in February tutaanza kufanya ECG training. Hii ni mfano wa stenosis. You have the vessel which has 3 layers, the outer layer, middle layer, and inner layer, the adventitia, media, and intima layer. Ambayo between the adventitia and media layer unakuwa kuna accumulation of cholesterol or atherosclerotic plaque which narrows the vessel. Ndio cause hasa ya ischemic disease. Hasa chronic ischemic disease, you just have a narrow vessel which has not thrombosed. Hapo unakuwa na chronic coronary syndrome. Mtu anakuwa anapata chest pain on exertion, akitulia yuko vizuri. Kwa sababu the vessel is narrowed, but if you give it the demand, if you increase the demand, supply inabaki pale pale, mtu anapata chest pain. Lakini ikibreak ikasababisha thrombosis, the vessel fills in with a blood clot. That is acute ischemic disease. This ST segment elevation is an emergency. You have only 90 minutes before after which you have lost significant muscle, na mtu anakuta anabakia na permanent damage to the muscles na anakuja kuishia na heart failure. So this is the whole basic thing which happens with ischemic disease. Chronic ischemic disease and acute ischemic disease. Acute is when you have breaking of the plaque causing thrombosis within the vessel. So ukiwa na hii bila kubreki, ukifanya zile biomarkers they always be negative, lakini ukibreak zile biomarkers zinakuwa zinapanda kama troponin na CKMB zinapanda kama una acute thrombosis, which is basically a clot within the circulatory system which blocks the flow, forward flow or distal flow of blood to the myocardium. So you can do mitral valve repair. It's more complicated than the normal PTCA, but you can do various mitral valve treatment, either balloon, you can use repair, you can as well. There is a new technique which is called mitral clip for those who have chronic mitral regurgitation ambayo hairespondi anyhow and you don't want to replace it. Unaweza kuweka clip ukapunguza ile aperture na ukakome umetibu mitral regurgitation. We can do device implantation by using Cathlab. Sasa generally tunasema huko mtaani tunasema pacemaker, lakini they are called devices. Kuna bradycardia pacing for those who have complete heart block, au watu wenye atrial fibrillation with the intermittent blocks, tunapatia bradycardia pacing ambayo ni basic bradycardia pacing. Lakini we have other devices ambazo zinakuja kwenye treat arrhythmias kama VT au VF. Wagonjwa ambao wanapata ischemic disease wanapata scars kwenye myocardium. When they have those scars, the scar act as a substrate to generate an abnormal circuit of electricity, which will always fire and cause arrhythmias. Ambazo arrhythmias hizo which are below the AV node na called ventricular arrhythmias. There are two of them, VT, ventricular tachycardia, na VF. VT ukiwahi unaitibu. VF you can always miss it unless una implant ICD. ICD inakwenda track na kuna kudetect, ikiona hiyo arrhythmia ina discharge energy, inakata hiyo ni cycle, inaanzisha cycle nyingine. Kwa hiyo these are the devices ambazo nimeshazisema tayari. This is how pacemaker is done. Unakata below the left or right collarbone, you access the vein which connects the right heart with the peripheral circulation. Unapeleka waya wako mpaka kwenye right ventricle depending on one lead or double lead, single chamber or double chamber. Kama ni single lead, unaweka only to the right ventricular apex. Kama ni double, unaweka kwenye left atrium as well. Kwa unaweza kupata ni single chamber au double chamber pacing. Unaweza kufanya pericardial synthesis. Actually ndio standard way of doing pericardial synthesis. Wagonjwa wana TB with massive pericardial effusion au pleural effusion. Sorry, pericardial. So huwa kwa kawaida unatakiwa ufanye kwenye Cathlab, ndio standard way. Wakati mwingine tunafanya bedside, we using echo machine, lakini standard way ni kufanya kwa kutumia Cathlab. Na kuna special catheters unaingia kwa kutumia guide ya fluoroscopy, na unatumia large bore catheters ambazo zinaingia na kudrain ile pericardial effusion either kwa sababu ya infection au hata wakati mwingine wakati unafanya procedures ukapata traumatic pericardial effusion. Kwa hiyo standard way ya kufanya ni kwa kutumia Cathlab, sio bedside wala with guide of echo. Kama huna option you can do that, but the standard way is using Cathlab. We can use closure of device. Hapa ni ASD, atrial septal defect. Badala ya kufungua kifua ukaweka patch, depending na suitability of defect, unaweza ukafanya percutaneously kwa kutumia Cathlab guide. Siku hizi hawafanyi kufungua kifua kwa sababu it leaves with a lot of kwanza it's dangerous. It leaves a patient with a lot of problems after that. You can do it for ventricular septal defect, for atrial septal defect, for PDA, and for other venous atriovenous malformations as well, depending on where it is and if it is suitable for device closure. As we conclude, we can do a lot in Cathlab. For diagnostic and treatment ranges from revascularization to device implantation, lakini pia intravascular au vascular diagnostic procedures can be done in Cathlab. So if you have a patient, especially children who have congenital anomalies, usiishie tu kufanya echo na other non-invasive, kunafanya pia diagnostic and treatment procedures with Cathlab. We have them and we can do at our place. This is our Cathlab, how it looks. This is our staff doing the procedure. Na hii ndio ambulance yetu ambayo tunaitumia kwa ajili ya rescue na first response. This is where we come from. Tuko Bunju B on the way to Bagamoyo, left side njia Mabwepande, about 1.5 kilometers from the Tarmac Road. This is our building. Asanteni kwa kusikiliza. Karibuni kwa maswali if any or discussion for that matter.